Okay, so we have a patient with fundal varices who has history of bleeding. So find the penetrators, trace them. Okay, so as we do underwater film, this is large spleen, and this is the conglomerate of varices. So this is the fundal varices that we are dealing with. Okay, the scope pakadna. Yep. So I think one first thing, let's measure what this is the size of the varix. Now if you see in totality, starting from here, this is the muscle layer, this is the extra gastric one. So this is intraluminal, and this can go all the way, say, at least till here. And then you can measure the other dimension, which is here. So you're looking at a 3.5 by 1.3 centimeter varix. So it's fairly large. And it's one option obviously is to you go ahead with coiling and combination with glue. We'll show you how we do that. The other thing, again, we'll go into, like we showed earlier, we'll go ahead and find the penetrators and trace them. So this one is a penetrator here. So this is feeder of the varix, or the penetrator, or the inflow tract, which is what I feel this is. So we can trace this one. Let's see. Go back here, and right. So there it is. That's your penetrator. Then as we trace it, go around, trace the vessel, which is this one. And then we trace it up here, down here. Then it goes down over here. And then from here, it makes a turn, goes. So it's going here. Go back to this one again. Yeah, I think this is the one again. So trace it to the splenic hilum first. This is liver, this is the portal vein, and then you can see this is the branch coming off from here, and then as you trace this going up here, and then it goes down, right there, and then through this you here, then you follow this here, it goes up here, and from this right there, and then coming from right there is the penetration into the varix, right? So this one here is the penetrator, which I'm going to be concerned about. And let's see, let's measure it. Yeah. So this, let's see, is 7.1 mm. So not very big. So I may use a 9 mm coil for this particular penetrator. And that's what I'm going to do first. So what we'll do is we'll go ahead and target the penetrator, maybe larger, maybe 9 mm coil. Do you have a 9 or 10 mm coil? Huh? Yeah, we can do maybe a 10 mm coil for that one, right? Okay, good. So that I'm pretty comfortable with. Yeah, right there. And then any other penetrator. Let's search and see. So I think that's pretty much it, right? There's one here, which is what we have seen, and then on this side we do have penetrators over here. These ones where the arrow is, right? So let's see. So you can trace this particular one to. Okay. So this is the one, right? So this is going in, connecting with this. This goes up, right there. Now let's trace this one. So trace it, going down. So we see going down here. So adrenal, so it's right in front of the adrenal gland. Right there. So I have to now turn my scope, go all the way back there, find that exact view. Yeah, okay, so we got the same view. So this is the adrenal gland and this is the vein in front of it. It's coming from there, goes down, goes here, and then it's sort of going there, comes up, goes here, turns around, Yep, that's right. Yep. And then it goes down here, and then it continues on to the structure down here, which is the left kidney. Can't see that very well, but that's left kidney down there. Trace. Yeah, okay, well, here it is. Here is, yep, left kidney right there. So this is the renal vein from the left kidney, and then we can trace this out right there, and then from here is that outflow tract. So it's a gastro-renal outflow from here. And we confirm that again. Okay, cool. Okay, so let's see now. Okay, can I get the needle? So the first thing I'm going to do is going to get into the, yeah, right this. So what I'm almost going to guarantee you is that when you put the needle here and inject, it's going to go here. So that means you've done the right thing. I'm happy to have a bet on this one. Anybody wants to bet? No, I can be wrong, man. All right, let's see. Okay, can I have the 10 mm coil? Okay, and let's see. Pulse wave Doppler. So I'll show you. It's a venous structure now. It's not pulsatile, it's a venous structure. Flow is 20 centimeters per second, so yeah, it's reasonable flow. And then we go back to our F imaging here. Okay, ready, guys?
Yes, yes.
Pulse now. Okay. Yep. Load the needle with the coil ready.
Ready. Tell him.
Where's nail?
What will I do?
Yeah, tell me. Questions? Yeah, go ahead. Tell me what he's saying. Wait for her to come. Of the portal vein. Yeah, so we can go, we can go into the diurnal bulb. Yep. So that's your portal vein, right? Going into the hilum. Now there will be some collaterals from here, but transduodinally you won't be able to trace them. So this is going down. Yes, 10 mm coil. Let's do it. Yeah. The other thing you can see is this ecotexture of liver, which is pretty coarse. This is suggestive of a pretty hard liver. So it's a coarse ecotexture, and yep. So let's see. Where's the portal vein here? So this is another way, right? Transgastric that you're seeing, and this is the portal vein, right? Going into the liver. This is the collateral coming from it, right? Somewhere here. Or is it what this one here? Probably just distal to it, right? Yeah. Which is where this thing is, the pointer. And you can trace it coming here, going here, right? So this is coming from there, and then you can do the reverse tracing, going up. Right there. It goes up. Tracing, yep, and there you go, it's penetrating. You see? This penetrating, which is here. So now we've traced it both ways. From the portal vein and then from the, varix itself. Okay, let's do it. So I want to get a position which is stable. So I think Yeah, I think this is where we want to go. Okay. Okay. Yeah. So that's what I've started doing now. I put an effort to find the feeder and go for it. I do it right at the penetration. I'll show you how. Yeah, so obviously the position is a little odd because I have to do either this way or I can go all the way down and see if that gives me a better position. Whether that's okay. Can you do it this way?
हाँ ठीक है.
Can you increase the height of the bed? That's what happens when you're absolutely ready to put the needle and there's something goes off. Yeah, so here's what I'm going to do. I'm going to go microscope. Yep. You have a NS flush or
रेडी. मी लोड करून दिला
No?
तुम्हाला.
everything okay? Can I? Shall I leave? So this is sort of the site to go. Ooh, I'm in. All right, sorry, I'm in. Pakda. Yep, we are in. Right, so that's the location. That's the feeder,
छोटा नहीं
right?
होता का 10 है.
Nice, perfect. Go ahead, put the coil. Oh, I missed the flow in the varix before. Should have done that quickly. Yep, okay, that's lovely. Very nice. Okay, very nice. Very nice. Okay, that's great. Okay, now you see, as soon as we did that, you see there's activity, bubbles in the varix. You see that? So she'll put some NS now to show you. Hold the scope now. Okay. NS.
Injecting.
Yep. Right, so it's gone in the varix. That's the inflow for sure, right? Okay. So I'm going to go ahead and put some glue here. Maybe 1 cc of glue.
गिव पत्ता.
Okay. Give me the. Increase, no, reduce, right? So you have to reduce the amount of glue that you're doing. Yeah, I'm going to do 1 cc of glue. Now, one would argue that if you've done the inflow and you've put the glue, that should obliterate the inflow and you will have to do nothing else at all. So let's see, how does it go?
अजून एक कॉइल. 6 mm 8 mm. भरपूर मोठी स्पेस होती तिथे.
Yeah.
आता छोटा झाला.
Fine, you want to put one more coil, can you do it?
6 टाकू.
Give anything 8 mm at least.
8
Don't
is
give me
8.
6. Maybe I'll put another coil there, so it's nicely packed. And, just keep him stable. Ready?
8
You
घेतला ना
have
दादा.
to see how the coil loading is, right?
Select.
So the coil we use are Cook,
Nestor.
what do you call it? Nestor coils, right? Yeah. You seen this before? These guys? Not, yeah. Okay.
ये पकड़ो.
It's been a few days we've done this coil thing. So putting another coil, and we'll follow it up with maybe a cc of glue. You want to do a little more? Let's do 2 cc of glue. This is going to go in the barracks and help
दादा
more.
2 घे.
Lovely, yes. Right? Very nice. Good job, good job, good job. Very good, very good, very good, very good, very good. Excellent. Okay. Hey, did you deploy it completely?
Yes. I wanted to.
I feel like it's something. Okay, no, it's okay. It's okay. It's okay. Fine. It's fine.
चेक करते.
Yeah, no, it's not. You'll have to push again. Push all the way. No rush. Push, 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 push. Yes. Now done. See the difference? Good.
सर 2 ml घेतलाय.
Yeah. So what ends up happening is that the glue is going to go sit on that coil. A little bit of glue is going to go inside the varix.
Injecting distilled water.
Okay. Yep. Okay. So you have to save it, right? Yep. Okay.
Injecting glue.
Beautiful. Very good. Very good. Good job.
Injecting distilled water. थांबा. आता बाहेर घ्या.
Okay. Just to pack it better.
It's just your feeling that you need. Which comes out your practical, your previous experience.
Yeah. See, gone. The whole thing is gone. Outflow, we'll see. Yep, that's it. I won't have to do anything. Just check the scope, guys. Check the scope. It's done.
इधर से मारते हो वो पानी का बोल
Well, you know, it's going to coil and it's going to obliterate the vessel over time. Now, yeah.
लागला नाहीये.
इधर से बंद है.
ठीक है.
Everything looks good?
हाँ हाँ काहीच नाही लागलं.
Perfect. Good job.
But I don't know.
What's that? Yeah?
Thinking in an acute situation.
Uh-huh.
It's so different. Because
With a US, you know, you can just go in the.
what do you think is going to happen in the future? Like you can know that the patient with gastric varices is bleeding.
Yeah.
You think this could be more effective
Yeah.
going down with the, but we have to be sure that it's bleeding from the gastric varices, not from like any source. Or do you think we should go down just with the normal scope and then if you see like it's a matter of time, or best option? What do you think?
Well, I mean, if he's bleeding and you know it's from gastric varices, unless it's a spurter, it's spurting in front of your eyes, then you want to just go and fix it, right? But if you have some time and you know it's bled, like in this case last night, or you go and see that, hey, I mean, there's a sign, it may have bled from there, it's not actively spurting in your face, then you just take your time, do it the way you want to do it.
In an acute situation when there is a bleeding, it's impossible to
Yeah.
do this guy.
I mean, when it's bleeding in front of your eyes, you can't spend time figuring out the inflow and the outflow.
Are we
Right.
putting
Yeah,
more
that was
coins?
one of my main question.
Yeah, no, then you don't have time for it. Then you just put the needle in the glue, in the varix, and then just put it, right? Now, here's the thing, right? I mean, post this, now you see the entire thing is like completely,
Yeah.
I mean, there's really nothing left, right?
Yeah.
You see?
सर टाकत आहे तुम्ही.
And no, we are done,
ठीक आहे.
okay? And I can't even trace the outflow there very easily, which is somewhere here, okay? So now, no, wait. Guys, sorry. Can you guys wait? I may have to do something. Yeah. So here's the thing. This is the residual part. Okay. Can you hold the scope?
You have to hold it.
Yeah. Hold it. Scope. Yeah. So you see, what's going to happen is most likely I don't have to do anything to this, right? Because most likely, I mean, you already see this stasis of flow. The whole thing's going to die on its own now. Because I've completely stopped the inflow. But let's see what we find in terms of this flow speed here. Right, so it's so small, it's like 2-3 centimeters per second. So whether we need to do it or not is truly debatable because this is all there is left, right? And there's so very little flow here. See here? And then this flow is 90% reduced right now. And then this This is going to go out from here into the, and then exit from there, the blood, right? So whether we need to address it or not is a good question. People would say based on prior, evidence that you can leave it alone, just because you stop the flow of blood coming into it, and it's really gone down. So this will die. If we need to do, it's so small, I'm just going to leave it alone, I think. And then this is the outflow coming from there, right? So, yep. So I'm going to see what happens to him. I'll call back in a month and see. I think he should not have any more bleeding with such a slow flow right now in that. Agree with me?
6, 7, 9.
We can put more. Then, that's the whole point of doing penetrators, to not bother with all this. That the flow is so low that there should be no bleeding in there.
So you can have multiple feeding vessels.
Yeah, you can have multiple feeding vessels, and then you have to address the multiple feeders if that's the case. Okay?
Risk of embolization is more if you target it somewhere around here.
When you target somewhere here, it's going to go out. It's going to go out, it's going to embolize. Why did it inflow? So inflow, it went in, and it has not reached the outflow at all. So I know 101% sure there's no embolization happening here. Why? Because I did the inflow, the glue is only in the varix, it has not gone out, and I saw 2 cc would do fine, and it's fine. And most likely I don't need to have to even do anything about this, because you should not bleed from there, technically.